Good evening, everyone. I'm Ann Taylor. I'm the Director of Community Engagement for AIM at Melanoma. We're so glad to have you with us. We have people who are joining us via Zoom and Facebook and YouTube. I will have an opportunity to tell you more about AIM at Melanoma later on after tonight's presenters, but I know that you are anxious to hear from our panelists from the Angeles Clinic and Research Institute. I want to thank Dr. Hamid and our panelists for their collective wisdom. Let me explain to you how you're going to get your questions to, hello, welcome. I want to explain how you are going to get their questions to you this evening. If you are joining us via Zoom, what you'll do is look at the bottom of your screen, and there you will see a button that says Q&A. That's where you'll put your questions, and Dr. Hamid can cull through those and decide which ones he would like to select for our live Q&A session. If you are joining us on YouTube or Facebook, then what you will do is you will put your questions into the comments field, and we'll transfer those over to Dr. Hamid. And so with that, I'm going to pass the podium, the mic over to Dr. Hamid, let him open our symposium. And once again, thank you for joining us.
I just wanted to introduce everyone in here today, and we'll begin with the agenda. But first, this at the Angeles Clinic and the AIM Melanoma collaboration could not happen without the guidance of our CEO, Dr. Lawrence Piro, who has a few words for us.
Just want to welcome everybody. This is the 15th year. It's been a great partnership with AIM. Reaching people is not an easy thing to do. It seems like the world is, very connected, but actually finding the ears that need to hear your message in terms of cancer screening and awareness and new treatments and clinical trials is not as easy as it seems. And so this particular meeting, which has existed, as I said, for 15 years, has been a great way to reach people. We've reached over 7,000 people in the years that we've been doing this with access to clinical trials that they otherwise would have known about and potentially life-saving information. So we're glad you're here. We have, I think in the past, we've had as many as 1,500 remote viewers. And so I imagine that we'll have that today, often from multiple countries and all over the US. So I welcome all of you. I thank our faculty for taking their time to do this. This is one of the highest callings as a physician, is to reach people with information that can cause them to have a different course. So welcome and thank you to the faculty, and let's have a good conference.
Thank you so much, Dr. Piro. So we have a great agenda for you today. As you'll remember, that these meetings are videotaped. They will be available for you on our site and on the AIM site. Our goal here is to educate, to have good discussion, and to move the field forward, and that can't happen without your involvement and our collaboration together. So with that, I want to go into our first speaker, who's Justin Moyers, who's here, who has joined us over the last couple of years and worked to build our immunotherapeutic program, our cellular, CAR T-TIL program. Dr. Moyers comes from a huge background of drug development. I look forward to hearing his thoughts, and welcome and take the cue.
Thanks, Dr. Piro. Thanks, Dr. Hamid. So I'm going to talk about kind of set the stage for all the other speakers. So I'm going to call this our Melanoma 101 talk. We're going to review the initial first line and second line treatments that patients with metastatic melanoma may receive as part of their care. So quick agenda. So we'll talk about the current first line treatments, and we have some long-term updates that have come out over the last basically year on several of these, and then talk about some selected second line options in immunotherapy, targeted therapies, and cell therapies. If you've attended any melanoma talk in the last several years, you'll see this awesome timeline of drugs that have been approved. Here's the most recent one with the update of lifileucel, the TIL therapy last year. And so, we know that there were few approvals until 2011. And since then, there's just been a number of approvals in immunotherapies and targeted therapies. First up, there's the Keynote 006 study. This was the trial that established pembrolizumab as a checkpoint inhibitor with good efficacy in metastatic melanoma. They compared pembrolizumab, which is anti-PD-1, to ipilimumab, which is anti-CTLA-4. This is the 10-year follow-up. So you can see out at 10 years now, we see that there's long-term survivors of metastatic melanoma, and that tail really doesn't change much after 6 years. So people are surviving with melanoma on single-agent checkpoint inhibitors for a decade. The biggest trial one of the biggest trials that changed everything was a checkpoint 067, where this is where we found out that dual checkpoint inhibitors were better than single-agent checkpoint inhibitors for untreated metastatic melanoma. And so it was 3 arms. Either people were given nivolumab, also known as Opdivo, or nivolumab plus ipilimumab, or ipilimumab alone. So it was 3 different arms of those two drugs in 3 different permutations. And the initial trials, we saw that the progression-free survival, so the time it took from the cancer to grow or not respond to the immunotherapy, was longest in the double combination. So these data have been ongoing. They've been following patients for now 10 years. And so this is the last update, just published a couple months ago for the 10-year outcomes of this data. And so what we see is that after 5 years, not a significant change too much in people having recurrences or deaths after that time. But I think the interesting thing to point out is that if we look at the melanoma-specific survival, when you're out at 10 years, people start to, have other illnesses, diabetes, heart disease, other cancers that can, affect their lifespans. And so if you look at melanoma-specific survival, meaning people who died from melanoma specifically, there is not significant changes for any 3 of the arms between that 5-year and 10 years. So still over half of people are, living with remissions for their melanoma at 10 years if they got the double checkpoint inhibitors. Very great stuff. And one of the also interesting things is if you were without melanoma at 3 years, so surviving and not having your melanoma progress or grow at 3 years, few people had additional recurrences after that time period at 10 years. So most of the people, if they're having recurrences, are happening in that first 3 years. So that's an encouraging thing that we can tell our patients. If you're doing really well at 3 years, we think your melanoma is going to be under very great control based on this data. Other interesting part to kind of pull out of this big data, this landmark trial, is that depending on how much the tumor shrank on any of these 3 arms, that correlates with how well you'll have remission from your melanoma. So the more shrinkage, more likelihood that the melanoma will remain in control at 10 years even. Also interesting, one of the things we always point out is there's side effects with these immunotherapies, but it's not a horrible thing to see some side effects with immunotherapies, because we see that if you have some side effects with immunotherapies, you're likely to have a better response than if you don't have any side effects at all. So we see that people who had some side effects, their survival, their remission rates are much higher than if you did not have side effects. So moving on, the other combination is anti-PD-1, which is nivolumab plus relatlimab anti-LAG-3. This is the Relativity 047. This combination was approved within the last several years as well. This trial looked at previously untreated metastatic melanomas. They compared single-agent PD-1 versus this dual checkpoint inhibition with LAG-3 and nivolumab. What they found out was that the progression-free survival, or time it took the melanoma to grow, if you were on the combination, was longer than if you had just a single drug. So we found out that this drug combination seemed to be better than the single drug alone as well. That correlated to people surviving with their melanoma longer as well, if they got the combination nivolumab plus relatlimab. So moving on, the other first-line category to think about is first-line targeted therapies. What are targeted therapies? So in melanomas or any cancer in general, there can be mutations that form to cause the cancer to have unregulated growth. 50% of melanomas of the skin have a BRAF mutation. There's 3 different classes of BRAF mutations. The ones that we care the most about are these BRAF V600E. You'll see this information on your next generation sequencing, so the DNA testing of your tumor. We call this class 1. They are the ones that are activated by this mutation and cause unregulated growth. These are the mutations that are most responsive to the therapies that we have right now approved. So this landmark study compared 2 drugs that act on the BRAF mutation, dabrafenib and trametinib, in melanoma, and they compared it to, it was a phase 3 trial, so a large trial with 700 patients. They compared the combination dabrafenib and trametinib versus the old first-line therapy for this, which was vemurafenib. What they saw was that people's tumors took longer to grow on the combination compared to the single-agent BRAF inhibitor, and people live longer with this combination. Complete response happened in 47%, so the complete shrinkage of the tumors, at least temporarily, happened in nearly half the people with the combination BRAF and MEK inhibitors, whereas only 27, so only about a quarter with the single-agent BRAF inhibitors. There's multiple trials that have been looked at this combination. They combined them to find out that at 2 years with this combination, half the people were alive and their melanoma under control, basically. And if we separate out those responses for what was the best tumor response you had, so if you had a complete response, meaning the tumor shrunk to nothing, or if you had a partial response, or meaning that the tumor shrunk a little bit, or if you had stable disease, meaning the tumors didn't grow, but they didn't shrink too much either, the best responses, the best temporary tumor shrinkages happen in those who had a complete response at the beginning. So we talked about the dabrafenib and trametinib. There's actually 2 other sets of combinations basically made by different drug companies, vemurafenib, cobimetinib, and encorafenib and binimetinib. And they each have their own different set of side effects. So the pink are the dabrafenib and trametinib, the reddish are the vemurafenib, cobimetinib, and the orange are the encorafenib and binimetinib. You can see that if you break it down in side effects, different ones have different side effects. So the dab-tram doesn't have much of the eye side effects, but it has more fever. We tend to use, I think most of us, encorafenib and binimetinib. It seems to be the best tolerated, but any of these 3 can have different side effects for the individual. This moves on to, so we talked about immunotherapies and targeted therapies. Which one do we choose for first? Because we can only give one first. And so they ran a trial called the DREAM-seq trial to answer this question. All of the patients with BRAF mutant melanomas were randomized to either get immunotherapy first or get the targeted therapy first. And then once the cancer grew, they would switch over to the other treatment. We found out that it does matter. We found out that giving the immunotherapy first allowed more people to have remissions and control their tumors compared to those who got the targeted therapy first. So this really settled the question. We also see that about 46% of people, at least in this trial, had tumor shrinkages with immunotherapy compared to only 43% with the targeted therapy. And then importantly, in the second line, those who had the targeted therapy first, the immunotherapy just didn't respond as well. Whereas if you had the immunotherapy first, the targeted therapy still responded nearly as well in the second line setting. Next question, which of those immunotherapy combinations should we pick? So we know now immunotherapy is the best to go for first. Which one do we pick? So this graph I really love shows grade 3 and 4 side effects, or those serious side effects that can lead to treatment or hospitalization, on the y-axis going up and down, and then on the x-axis going sideways. We see how long they worked for, and you can see that the Nivo-Ipi has the most side effects, but also works the best, whereas Nivo-Rela is pretty close. It works nearly as good as the combination of Nivo and Ipi, but doesn't have nearly the amount of side effects. And then each of the single agent checkpoints have less side effects and also less efficacy. So that naturally leads to the next question. Why not use all three at the same time? We talked about Nivo and Ipi and Nivo and Rela. Why not combine the three? So this is an interesting study. This is not yet standard, but I thought that I would include this. Our colleague over in Italy presented the trial of Relativity 048, where they combine Nivo, ipilimumab, and relatlimab. And they see that in this small group, look, there's only 46 patients in this trial, but in the other ones we saw hundreds. We see that people are getting remissions, having tumor shrinkage at a high rate with this combination. So hopefully more to come on this combination. After first-line therapies, so what happens if the tumors don't or start to grow after the first-line therapies are given? This is our NCCN guidelines. We have a whole list of things that we can consider based on BRAF mutation or not. Most of these are immunotherapies, and we'll go over a couple of them. Why do we think about immunotherapy combinations? So immunotherapy has allowed field of oncology to change. We have even durable cures like we talked about. However, some people's tumors are cold. They don't respond to the immunotherapy. So these combinations hopefully can resist checkpoint blockade due to several different modes, by changing the cytokines, by changing how the tumors present these antigens that allow the immune system to respond, and then also just causing death of the T cells that are regulating the immune response. And therefore, we need new therapies to try to overcome these obstacles that are hindrances to immunotherapies working well for all melanoma patients. These are some of the targets that we looked at. So, PD-1, we've talked about this. This is the pembrolizumab and nivolumab. CTLA-4, that's ipilimumab. And then what are the investigational ones? So, or not investigational, the newer ones, LAG-3. We have the relatlimab over on the right. There's trials going on in pretty much all of the other ones that were listed. GITR, we have seen trials in BTLA-4, OX40, 41BB. So what are some combinations that we are in the guidelines or people use? One of the ones that I like the most is, it's not approved, but we have phase 2 evidence, is the LEAP-004 study using a drug called lenvatinib, brand name Lenvima, plus pembrolizumab or Keytruda for melanoma after PD-1 drugs did not work. And how does this work? So we've talked a little bit about how Keytruda works. It activates the T cells to try to fight your melanoma. How does Lenvima work? It's something called a multi-tyrosine kinase inhibitor. It blocks several different proteins growing. So the thought is that it can disrupt blood vessels and allow for the immune system to target the cancer. This is a single-arm study, meaning that they didn't compare it to anything. Everybody got the same drugs. This waterfall plot shows tumor growth if the bars are going up, shows tumor shrinkage if the bars are going down. So we see that 65% of patients on this combination had some sort of shrinkage. There's an somewhat arbitrary threshold set at 30% shrinkage to call it verifiable shrinkage, and about 21% of patients got that. So pretty good combination to keep things stable for many patients. If it worked for patients, the duration it worked was about 8 months. Another combination we sometimes use after PD-1 therapies is something called TVEC. TVEC, I put the infographic here on the right. How it works is it's a virus, it's a modified herpes virus that's injected into the tumor itself. It then uses the tumor as a host to grow, and it releases these antigens, releases bits of itself upon breakage, which is attracted to by the immune cells, called dendritic cells in this case, and forms a response to attack the tumor. So this is a kind of causes inflammation in the tumor, allows the immune system to attack the cancer. We call these oncolytic viruses. So this trial looked at taking TVEC plus pembrolizumab or placebo plus pembrolizumab to see how well this combination worked in the first-line setting. What we saw is that if you compare the two, first-line pembro versus pembro plus the TVEC, we saw a slight improvement in how many patients were having tumor shrinkage, but it did not reach statistical significance. So it wasn't for certain without chance that this combination was better than the single agent. Nonetheless, it's something we consider in the second line therapy, especially for patients who have tumors we can feel and we can poke a needle into, put that modified oncolytic virus in. That also brings us to this next phase. So the next generation, is something called RP1. It's another herpes virus that's modified. Works the same way. It's injected to tumor cells, causes local infiltration, which activates these T cells. But the interesting thing about this is that unlike TVEC, where we've mostly only seen the tumors themselves that are injected shrinking, we're seeing tumors outside of that injected area shrink as well. And so we call this a spider plot. The lines start at the middle, and then like legs of the spider, if they go down, that's shrinkage of tumor. If they go up, then that's growth of tumor. The red ones are the ones that tumors are injected. The blue ones are tumors elsewhere. And so you see not only the red injected tumors decreasing in size, but many of the blue non-injected tumors are shrinking in size as well. This is one patient's example that was presented by Dr. Wong at ASCO, injected tumor in the forehead, but also having shrinkage in the liver tumor. Very cool stuff. So there's, at ESMO this last year, preliminary data for some of this was presented. We're seeing responses again in injected and non-injected lesions. There's ongoing trials to further take this information or this drug to further phase trials. Accidentally copying this. Next, targeted therapies. So what after BRAF and MEK inhibitors? What else is there? So one thing that's based on an older study in 2017 from the Lancet, if people have NRAS melanomas, there's targeted therapies with binimetinib. This was compared to chemotherapies. Remember, this was over a decade ago. And if you use binimetinib, that works better than chemotherapy for NRAS mutations. So still a drug that we can consider if people have NRAS mutations and we don't have other better options for them. We also look at the tumor DNA to look if there's something called fusions. If you see on the left, we call these translocations, the other name for them. You see pink and blue chromosomes. They do some handshake and they switch parts, and afterwards they have what's called a translocation. Few melanomas have this. I looked at this from the ACR Genie, has thousands of patient cases of NGSs. Over 90% of melanomas do not have fusions. Fusions are really uncommon. The most common ones are BRAF fusions, ROS, RET, NTRK, and ALK fusions. Why are these important? So these are the needle in the haystack cases. BRAF fusions, there's new drugs that are being developed for these. And there's right now really only single patient or small trial data. For one patient who had a SCAP2 BRAF fusion, they got trametinib, had a response lasting months of tumor shrinkage in their liver. There's also what we call tumor agnostic approvals, meaning no matter what cancer type you have, if you have this mutation, like a TRK fusion, you can get a drug that can shrink the cancer. So in this trial of larotrectinib, which is a TRK fusion drug, if you had a TRK fusion, most of the time your cancer shrunk. And if you look at this list of 30 odd patients or so, the green bars are, the dark green bars are melanoma. So a couple melanomas with TRK fusions had significant shrinkage, one of which had complete shrinkage of their tumors if you had this rare mutation. ROS fusions, similarly, a patient with melanoma got crizotinib on a case report, and it took their melanoma to shrink it basically down to nothing, at least temporarily. Had 2 years for this patient of complete tumor shrinkage. Another one, the last one that has a tumor agnostic approval is pralsetinib in RET positive cancers. Another uncommon mutation in melanoma, but something we look for in the standard NGS panel. Lastly, going to cellular therapies. This is an infographic I created to kind of explain to patients how this happens. So patients will have a tumor. An excellent surgeon like Dr. Ferries will take it out. They will isolate the TILs from the tumor tissue in the lab. They will expand or modify these lymphocytes that are extracted from the tumor tissue, and they'll make this TIL product. This can take weeks to months. And then they'll come into the hospital or clinic, get 3 to 5 days of what we call lymphodepleting chemotherapy to decrease the amount of lymphocytes, which are part of the white blood cells in the patient's bloodstream, allowing room for the TILs to be infused. The TILs are then infused, and then we activate the immune system by using up to 6 doses of something called interleukin-2, which is a synthetic version of a cytokine or a inflammatory protein in your bloodstream. How is this process developed, or how is it approved? So there's a landmark trial that of TIL, so tumor-infiltrating lymphocyte therapy, or using anti-CTLA-4 ipilimumab, done by the Dutch in advanced melanoma. They looked at comparing these two and second-line therapy. They found out that people had more remissions, lived longer if they got the TILs compared to if they got ipilimumab alone in this trial. You can see on the right, ipilimumab had far more growth than the TILs on the top group. The US approval was based on a composition of several trials with the Iovance product known as lifileucel. Overall response rate was 31% in these refractory patients who got TIL. This has led to the FDA approval of the first cellular therapy in solid tumors. And what are the side effects of this? Can mostly relate to the lymphodepleting chemotherapy, having your blood counts be lowered, chills, anemia, more things that are causing your immune system to be responsive, fatigue, and some other kind of immune-related side effects. So this is just a game changer for us. Many trials going on in this. They're using TILs in combination with other drugs, such as checkpoint inhibitors, radiation, targeted therapies, vaccines, and then also just modifying the TILs in some manner. This is the updated results of this. We see considerable tumor shrinkage from part of that Iovance trial. This has led to a next step where they're trying to compare pembrolizumab alone versus the TIL plus pembrolizumab to see how much significant improvement we can get for using TILs in the first-line treatment. So will TILs be a first-line treatment? That's what this trial is trying to answer. And that ends kind of an overview of our Melanoma 101 to as it serve as a basis for everybody else to expound upon.
Thank you so much for that great presentation, and the infrastructure of which we can use to think about the talks that are here, how we care for our patients and ourselves if we are the patients. But also, it cannot be minimized how important the work that has been done in melanoma in the first line has contributed to other solid tumor care, all of the checkpoints and the targeted agents and the BRAF agents, but also how it has translated into the care of other types of melanoma, including ocular melanoma. Here at the Angeles Clinic and Research Institute, the ocular melanoma guru is Dr. Indrajit Memi, who's been here for half a decade. Seems like just yesterday. So I will hand off to the young Dr. Memi.
Thank you very much, Dr. Hamid. Yes, it's been about 5 years since I started, and it's my third or fourth presentation. It's been really good experience so far. So today I'm going to take some time and walk everybody through current care of ocular melanoma and what are some of the upcoming therapeutic options for our patients. So this is just my roadmap for this presentation with background, prognosis, staging, and what's missing from there is the talk on adjuvant and neo-adjuvant approach, and then subsequently metastatic disease management. So these are some of the spaces where ocular melanoma or uveal melanoma can develop. And as you know, that this is not the most common malignancy, but it is one of the most common malignancy of the eye in adult population. About 2,000 cases in the US each year and about 8,000 cases globally. As we know, the risk factors of sun exposure for cutaneous melanoma, that's not the case for uveal melanoma, and those risks are still being looked at. But other risk factors that we know are the nevus in the choroidal space, melanocytosis, any family history of uveal melanoma. Some of the other germline mutations can also lead to this. So once a patient is diagnosed with primary ocular melanoma, it's important to look at their staging, their primary melanoma staging, because that informs us what are their future risk of developing metastatic disease. We know that about 50% of the patients will go on to develop metastatic disease, and it can be or has been in the past quite challenging to manage these patients. So some of the prognostic or predictive prognostic marker that we use are the tumor size itself, basal diameter and height. And additionally, we've been using gene expression profiling in uveal melanoma. That's very well studied, where the tumors are actually sequenced and split into either class 1 or class 2. And based on that, we know that their long-term outcomes can be predicted fairly with good confidence. As you can see that, if you're a class 1 subgroup, you're likely to do fairly well, and they tend to be very different in terms of their recurrence risks and how far they recur. They tend to recur later in time rather than early on, where class 2 are the sort of early recurrence patients. And then some of the additional information that we've seen is the PRAME antigen, which we'll talk about a little bit later as a therapeutic target, but it is also a prognostic marker. Individuals who have ocular melanoma that are not only class 1 or class 2, but are also differentiated based on their PRAME presence. Having PRAME marker on the uveal melanoma actually portends a poor prognosis and decreased overall survival. So going back, looking at, hey, is tumor size good enough as a prognostic marker? Well, not exactly the case. We still tend to use that, but most often the gene expression profiling and PRAME and monosomy 3 are some of these markers that we will use to define a uveal melanoma being a high risk or not. And why is that important? Because that allows us to at least look at these patients and trying to offer them therapeutic options, either in standard of care or in clinical trial setting, to reduce their risk of recurrences in the future. In the past, this task has been very challenging. As you know, the uveal melanoma is not the most common disease. So doing large trials that are required for adjuvant therapies aren't all that easily done. But that is changing because, the road's been mapped for us with number of clinical trials, with number of different target therapies or immune therapies or intralesional therapies to see if it could reduce the risk of recurrences. Most of these trials have led to sort of mixed results. Occasionally, I'll see patients who've received sunitinib, a multi-tyrosine kinase inhibitor in adjuvant setting, because it's known to improve overall survival in patients who are under 60 years of age. But the rest of them are sort of a bit of a mixed bag. Until last year at ASCO, when one of our colleagues, Dr. Apiswan from, I believe he's at Georgetown, he presented the data on ipilimumab and nivolumab that was used in treating patients who had high-risk uveal melanoma. And what high risk meant was their class 2 or their tumor's basal diameter was greater than or equal to 12 millimeter. And these patients were treated with nivolumab 240 milligrams every 2 weeks and ipilimumab 1 milligram per kilogram every 6 weeks, up to 48 weeks, with a primary endpoint of 3-year distant metastatic-free survival, and also had a couple of secondary endpoints. And they compared it to a standardized control group from the cooperative Ocular oncology group. And when they did this sort of synthetic arm comparison, the individuals who that received ipilimumab and nivolumab actually showed improvement in their DMFS outcomes. It was 70% versus 43% with the propensity score matching method. And then median DMFS wasn't reached in these patients. So as you can see, that this is a reasonable option for some of these patients, but this is a small study. We know that ipilimumab and nivolumab could be quite toxic for some of these individuals. So we do need bigger numbers to sort of make this as a standard of care for our patients. So since the roadmap's already there, now we're looking at some of the other therapeutic options that could play a part in adjuvant sort of therapeutic space. And we're going to talk a little bit later about tebentafusp or Kimmtrak, which is FDA-approved therapy for HLA-A*02:01 positive patients with metastatic uveal melanoma who haven't seen any treatment before. It's shown overall survival benefit, meaning it's already proven to work in advanced stage. Can we bring that therapy in early setting, in adjuvant setting, to see if we can prevent some of these recurrences? So this ADAM trial, which will be open at our site soon, and is actually planning to be open at multiple sites in the United States, looking at high-risk patients who had TNM stage 3 or gene expression profiling class 2 or have monosomy 3 in their uveal melanoma. They have to be HLA-A*02:01 positive, and the treatment is with tebentafusp up to 6 months, and then endpoints of primary at relapse-free survival and secondary endpoints being overall survival, toxicity of the therapy, and quality of life. The flip side of that is, what if you don't have HLA-A*02:01 allele? Then what is your adjuvant option? We can't leave you alone in a sense, because if you have high-risk melanoma, for example, GEP class 2, what are some of your options? So, well, there's been sort of a preclinical work looking at BAP1 mutation and what its role is in metastases driving genes. And we know that they're upregulated. And quiznostat is a drug which inhibits histone deacetylase 4 enzyme, and it sort of decreases these metastatic driving genes and hope to reduce the risk of recurrences. So that's the preclinical work. So based on that, University of Miami team has put forward this trial that will be opening up. And it's looking at quiznostat treatment, 12 milligrams via capsule taken orally 3 times per week for a 21-day cycle and total of 17 cycles. So roughly about a year of treatment. And with the primary endpoint, again, of distant metastatic-free survival, with the secondary endpoint being progression-free survival, overall survival, first site of recurrences, and adverse events. So we're actually very excited to look at these options, multiple option in adjuvant setting with a really good scientific background or already clinically established benefit. A few years ago, we had only one therapeutic options in metastatic setting, and now we have more than few, and we're talking adjuvant therapy in uveal melanoma. And on top of that, we're talking about neo-adjuvant therapies in uveal melanoma. What is neo-adjuvant therapy? Before the primary eye tumor is treated by radiation, the typical plaque therapy, or for some of the individuals that need their eye enucleated, can we give them treatment to reduce the amount of radiation or the plaque size, or can we sort of reduce their risk of enucleation? That's the neoadjuvant approach, and it's proven to be amazing in cutaneous melanoma. And can we apply that sort of principle in uveal melanoma as well? There's been a signal that's been seen using darovasertib, the IDE 196 drug from IDEA, that's already in first-line phase 3 study in metastatic uveal melanoma, and seeing if that could be applied in neoadjuvant setting before the metastatic disease is developed, and to reduce the size of the tumor, reduce the chances of enucleation, so they've seen some responses, median reduction of about 47% in the tumor. Most of the patients benefited. So based on that, the neoadjuvant study is ongoing, and hopefully we have more data to report on that. Additionally, the neoadjuvant study by Aurora Bioscience, they're looking at a virus-like particle packaged that's injected close to the tumor in the eye, and that leads to destruction of the cell membrane of the tumor and releases these signals that the immune system can pick up and hopefully learn to control the uveal melanoma cells whenever they move somewhere else or recur. So again, this trial is ongoing, and hopefully we'll have some data to present on in the futures. So as we already talked about, that a lot of the patients, or 50% of the patients, will develop metastatic disease, if they are high risk. And many times this metastatic disease tends to be in the liver. Up to about 80% of the patients will have disease in the liver. So are there mechanisms to treat the liver only rather than treating the whole person, which usually leads to increased side effects? Well, yes. There are a number of liver-directed therapies that are available, and a lot of them shown limited benefit, not overall survival advantage, but some progression-free survival benefit. And there are a number of different ways: immunoembolization, chemoembolizations, radioembolizations, perfusion of the liver itself with chemotherapy. And one such thing or therapeutic option is percutaneous hepatic perfusion, PHP, which actually is already FDA approved over the last couple of years and is in application. And here we use to isolate the liver supply of the, blood supply of the liver, and infuse it with melphalan, high dose. And that's shown to decrease the liver burden. And most of the time, the toxicity tends to be limited, and it's mostly the cell counts that decrease in nature. Some nausea, vomiting, increase in liver enzymes have also been seen, but this is actually FDA-approved therapy that is available at selected centers. Okay. We talked about, Dr. Moyer spent a good bit of time on targeted therapy. Are there opportunities for targeted therapy in uveal melanoma? Well, we know that lots and lots of the uveal melanoma have GNAQ, GNA11 mutations that seem to drive the cancer, and their downstream signal, can we interrupt that? And that's the basis of darovasertib with crizotinib to see if that could be sort of applicable interruption of the signal transduction to improve patient outcomes. In the past, other protein pathways been looked at with sorafenib, solumitinib, trametinib, and most of them have had very limited overall responses, not durable, toxicity issues, so they haven't been really widely used in practice. So this is the IDEA 196 compound, or also known as darovasertib, that showed benefit in an early phase study with a 50% overall response rate in the first line metastatic uveal melanoma, 30% overall response rate in patients who have received prior therapy. So based on this data, the phase 3 study is ongoing, and we'll have some data available to report in the future. We also know that immune system is quite important in cancer control, especially in melanoma. However, uveal melanoma is what's thought to be a cold tumor. There are not a lot of immune cells present within the tumor, but there is a small group of patients who still benefit from immunotherapy. That's been demonstrated in 2 separate trials, one led by MD Anderson team, another one in Spain. Both of these studies used ipilimumab, nivolumab in metastatic uveal melanoma that hadn't received prior therapies, and showed about 18% response rate. Some of these responses are quite durable. And we didn't see any newer toxicity in uveal melanoma because of ipi-nivo. So it's an option for some of our patients. So one of the most interesting sort of upcoming studies, I think, is for patients who are HLA-A0201 negative, or potentially, not candidate for whatever reason for IDEA study. I think CHOPIN trial looks very promising, even though it's only a 7-patient data that looked at combination of ipilimumab and nivolumab and liver perfusion with chemotherapy. And this is shown about 80% overall response rate with 1 complete response, 5 partials, and 1 stable disease. I think it's a story that's developing, and we look for more data in this and expand on this experience. Next, to talk in space of metastatic uveal melanoma is, again, continuing with immune sort of control of cancer. And we know that T-cell, cytotoxic T-cell are very important, but we need to get them to the right place. So to do that, it's these ImmTAC class molecule that bring in T-cells from the periphery into the tumor to control metastatic uveal melanoma. And this is established by demonstration of overall survival benefit with tebentafusp in metastatic uveal melanoma, published in New England Journal of Medicine in 2021. And it showed that, in HLA-A0201 restricted patients, when tebentafusp was given and compared to either pembro or ipi or chemotherapy, the overall survival was increased for patients treated with tebentafusp. And now we have 3-year data, follow-up data, and that still shows the ongoing benefit. The median overall survival for tebentafusp was 21.7 months, and for the control group, it's 16 months. So obviously showing benefit with the risk of death at with 0.5%, I mean 50% reduction in risk of death. Most of the adverse events that tend to happen with Kimmtrak or tebentafusp, they are focused in the first 3 doses, and that's mostly cytokine release syndrome, fever, chills, and most of these low blood pressures. Most of these are low grade, and they tend to improve typically with hydration, acetaminophen, and things like that. In a small, very tiny fraction of patients, they may need steroids or other ways to improve their blood pressures. And skin rash is quite common in these patients, but typically improves with topical steroids and rarely oral steroids as well. other ways to bring these T cells. As we talked before, that PRAME is an antigen quite widely expressed on uveal melanoma cells, in addition to some of the other tumors as well. And Dr. Hamid's presented this data at ESMO a couple of years back, showing that this is an approach that potentially is meaningful for uveal melanoma patients. And there were a handful of uveal melanoma patients, but they had ongoing benefit and durable benefit. So we'll look to develop this story further in the future. Dr. Moyers talked to you guys about RP1, the modified virus injection into metastatic site, and showing benefit in the uninjected lesions as well. So RP2 is the counterpart here to RP1 in combination with nivolumab to show you benefit in a metastatic uveal melanoma. And this trial is ongoing, but the phase 1 study showed that there is a potential for benefit when you're looking at RP2 in uveal melanoma. So these are the 17 patients that were treated with RP2 and nivolumab together in a single arm study, objective response of 29.4% and a disease control rate of 58.8%. Safety, most of the toxicity are in the injected lesions or injection site reactions. Significant number of these patients underwent intrahepatic injections without any significant issues. These are some of the characteristics of these patients that were treated. So there's ongoing trial. Dr. Moyers also talked to you about the TIL. There is signal of TIL in metastatic uveal melanoma, but number of patients treated is small. So this is not a complete story, but we look to see its development later. You can happily ask any question, answer any questions.
But we'll leave the questions till the end. And so while we give some time for Dr. Mehmi to rest his voice and recover, we'll move on. See if I can get my slides up here and talk to you about adjuvant and neoadjuvant therapies for melanoma. This is a very happening field, melanoma, but also in every other solid tumor, as we have spoken. Of. So what is neoadjuvant therapy? What is adjuvant therapy, and where do we go? I realize that we're speaking to a group of patients and advocates and physicians who are well aware of what's happening in melanoma, but in every other solid tumor, when we have something that works in the metastatic setting, that helps patients do better, live longer, and have long-term benefits, which means no side effects, living longer, and it shows durability. What happens is we bring it earlier and earlier. This is not a model that was built purely in melanoma. It's a model that's been built in other solid tumors, and I'll explain to you. Most of us know someone who's had a breast cancer, who had the tumor taken out like we have melanoma taken out, and then had the lymph nodes looked at like we do in melanoma for local disease, and then there was no evidence of that disease having moved from one area to another, still remained in the original area that it had shown up. And therefore, they saw physicians and they said, this is the risk of coming back. And drugs have been used for any cancers, but for breast cancer, there is chemotherapy and or hormonal therapy and or radiation therapy, not only to prevent recurrence, but to allow patients earlier to reap the benefits of this therapy and not have metastatic disease appear. And that's what we've done with these drugs that were just discussed in the metastatic setting, like anti-CTLA-4 therapy with ipilimumab, otherwise known as Yervoy, or anti-PD-1 therapy with Keytruda, or Opdivo. Some may know it as pembrolizumab and nivolumab. So what is shown here in a basic cartoon is what we want, that we cannot tell if there are any cells that are circulating in your blood that belong to your initial tumor. And therefore, if we give therapy, can we clean up what is there? And what is in that syringe at this point for melanoma is the therapies that have been approved in the metastatic setting. And this is a huge point to make, that immunotherapy has begun to be approved for melanoma all the way back from 2015, where the initial ipilimumab studies showed a survival advantage. And as I've moved forward, as you can see the black here, as they have moved forward, we have moved it on to other other tumors like bladder cancer here, breast cancer for triple negative breast cancer, and then other solid tumors, kidney cancer now, and esophageal and gastrointestinal cancers. So a lot to develop and discuss as we move on. So here is a easy cartoon that helps me understand what we're talking about. Neo-adjuvant therapy, which we'll get into later, is prior to surgery to activate the tumor, to attack by immune cells. Then we surgically remove, finish out therapy. Adjuvant immunotherapy is that which we see most patients for, where they have been diagnosed and surgically had their tumor taken out and their lymph nodes taken out by a world-class surgeon like Dr. Ferries, Dr. Fisher, a surgeon in your vicinity. And then we risk classify and discuss adjuvant therapeutic options. It's a long talk, and for me in my clinic with the patients that come here, it is a talk that can take time, multiple visits, and possibly a second opinion consultation with another opinion leader. So where did this begin and what do we know? I will set the stage by saying that there are clearly two therapeutics that are available in those melanoma patients who harbor the BRAF mutation that you've heard exists in about 50% of the cutaneous, those skin melanomas. Targeting that mutation with a regimen that's been approved. At this point, they're the drugs that target BRAF and the drugs that target MEK. The dabrafenib and trametinib has shown the ability to prevent relapse. Relapse means that the tumor has become back into your body and is now visible. So what we show here on the left is the ability to give targeted agents orally to patients with high-risk stage 3 melanoma. Stage 3 melanoma are those melanomas that had involvement of the lymph nodes in the body of the local area for only 1 year. And to show long-term, if you can see here, this is months from randomization, a significant benefit in relapse that even after just 1 year of therapy persists out 8 to 9 years and further. We've shown the same with anti-PD-1 therapy, pembrolizumab and nivolumab. Both have shown, in comparison to standard therapies for the placebo, the ability to prevent recurrence, which is relapse. So that is a standard for stage 3 melanomas when we discuss it. And also now for patients who have an area of metastases resected, have no other evidence of disease by imaging, exam, to benefit from this. That's the adjuvant. Adjuvant therapy is therapy when there is no clear evidence of tumor left in the body to prevent recurrence. And here again are two studies that show the ability for both PD-1 inhibitors to work. Many a time patients ask, are they different? And the answer is No, they both present the same benefit. The desire for this therapy is based on our ability to prevent the tumor from coming back and affecting your life, morbidity, or causing the end of life, mortality. So the other question that comes up when we talk to a patient is, well, you've shown that the PD-1 inhibitors here, like nivolumab, on the top line, they prevent recurrence. But as we've looked at the data, when you look at overall survival, they haven't affected survival. And that's partly because of our ability to give some of these therapies once there is recurrence. Why do we not see that benefit? Well, I think it's more to do with having seen it at some time in your therapy. But remember, a recurrence is not an asymptomatic case. At times you may have disease that goes to bone, brain, other places that causes disability. And that's what we're trying to also avoid. The middle trial is a trial that's going to help us that actually set the stage for this, and that is ipilimumab. In the time where there was nothing after anti-CTLA-4 therapy, compared to not giving anything, there was an overall survival advantage, and that's what keeps us going. The question will come when we look at the trials that randomize from early usage before recurrence to usage after recurrence. And that trial has been done and is going to move forward and give us that answer in the future. So what we usually say is, because anti-CTLA-4 therapy with ipilimumab beat observation and anti-PD-1 therapy beat anti-CTLA-4 therapy, therefore using the transitive property that anti-PD-1 is better than observation. That's a little bit of a stretch that we're trying to prove. Okay, what have we learned? There's a lot there. It's confusing, but it should only serve to push patients and advocates to ask these questions. Should my melanoma receive this type of therapy? What is new? What trials are there? Because at a time when we had stage 3 melanoma patients getting this therapy, we knew that there were patients with stage 2. That is only locally where the melanoma has shown up. Only there, and no nodal involvement. We knew that they had worse prognoses than some of the stage 3 melanomas. And so we did 2 trials that looked at comparison to placebo, and both of them showed a benefit in what was the primary endpoint, relapse, that coming back. We're still waiting to find out about overall survival, and you can see here both of them. Now these curves are hard to read, but you want to be on the curve that's on the top, and on the green top lines, those are all the patients with stage 2 high-risk melanoma that were treated with a PD-1 inhibitor. Well, you can relapse locally, or you can relapse in a distant fashion. Distant means in a metastatic fashion, and those are where we see of the morbidity and where we feel are directly related to mortality. And so at this point, we're seeing some initial evidence of that moving forward. Okay, if you've heard about adjuvant therapy, the question then becomes, what is neo-adjuvant therapy? Why do we have it? Is it better? Should I get this? Should I get that? Where can we go? And that is the idea of earlier blockade when you, earlier checkpoint inhibition, earlier immunotherapy when the tumor is in place. Well, that sounds, contra-normal, contra-intelligent. Why is that? Well, this cartoon that was put forth by Carolina Robert in France will give us some idea, and I'll take you through it step by step. All right. This is adjuvant immunotherapy. And on the top, you see distant microscopic metastases. That means cells that have gone elsewhere in your body that you cannot see by imaging. So we say, hey, it's only in one area, let's take it out and then give the immunotherapy. Well, what some may argue is there is only small amounts of tumor out there for the immunotherapy to react against, and therefore there may not be as strong of a recognition from your immune system to make those T cells, those fighting white blood cells that recognize the tumor and all parts of the tumor. All right, well, now I flipped. See here, this is adjuvant. Here, I flipped to neo-adjuvant. Again, adjuvant, neo-adjuvant, left eye, right eye. But the thought here is when the tumor is in place, there's greater bulk of tumor and a greater ability of those T cells that recognize tumor, these are those colored circles in there, to recognize not just the tumor, but recognize multiple different antigens or proteins that are specific for that tumor that create that immune response by saying, hey, this is not a normal cell. And then when you do the surgery after initial, 6 to 9 weeks of immunotherapy, then you have a more amped up, primed immune system. So we've looked at this in clinical trials. And as you can see here, because it's written down, it should be true, very convincing results in a perioperative treatment regimen. That's the neoadjuvant top part in blue before surgery. This was a trial done with 300 patients and reported by our friend Sapna Patel, who's now at the University of Colorado. And this was done to look at what happens if you get your neoadjuvant therapy, then do the surgery and finish out your 1 year. Remember, adjuvant therapy, only 1 year of anti-PD-1 therapy, or versus getting melanoma taken out and then receiving a full year of therapy. This was a randomized trial that was meant to decrease any bias. And when we looked at it in relapse-free survival, the blue line is where you want to be, and that was the neoadjuvant paradigm. What we're still waiting to find out is what about your overall survival, where there was a trend to doing better. The numbers were not big enough to show that, and we're waiting for this data to mature, to be older, to have more events, and to know what's going on. And that pushed us to say, wait, we have one drug, what if we gave 2 drugs early to get a better response? And this was very straightforward trial done by Christian Blanc in the Netherlands. I'll say that Dr. Ferris was the only investigator, only site in the United States to be part of this, but it looked at how about giving 2 drugs? And I hate explaining these things. You just have to make it very easy. So they took stage 3 with big bulky nodes. You can tell it's stage 3. And you gave them either 2 courses of combination ipilimumab nivolumab, that's PD-1 CTLA-4, like you've been introduced to by Dr. Moyers, in the neoadjuvant fashion. Then you go see the surgeon, they do the full surgery, and then you finish out for the year. Or you do the surgery and you just get your PD-1 therapy for the year. And guess what? The primary endpoint of event-free survival, that's relapse or mortality, etc., favored the blue line. That's where you want to be, higher on this graph. And that was the neoadjuvant approach. And when we updated it, this was the early presentation. When we updated it, it continued to have the same benefit if you looked many more months. And as I've said to you, distant metastases-free survival, that's what these letters, it going outside of the local area, it leaving Bronx and going to Manhattan and Brooklyn was you had better protection with the neoadjuvant regimen. What we also learned here on these crazy colorful charts you saw here is that you needed to do the surgery to understand what the benefit was. When we did just imaging, just CTs before going to surgery, there was a concern that there was no clear response, no clear benefit. Taking that tissue out pathologically and looking at it under a microscope, and then seeing how much viable disease, a path CR or a near path CR, that means when you look at it, everything is gone, the melanoma cells are dead, or the lymph node is cleared. When we looked at it, those people who had a major response did better. Those people who had a major response, again, you've seen these before. These slides should now be very easy for you. The green, the dark green, I want to be higher on these recurrence-free survival curves. That means I haven't recurred. And those benefited those people who had a response when you're looking in, and a major response. And that was the same for distant metastases-free survival. So not only did we see that, but we found that 60% of those patients who were on the neoadjuvant arm had that major response that we were looking for, which means possibly we could back off on further therapy. And there's trials that are looking at that right now. So we're understanding more and doing more. How do we really understand who benefits and doesn't? Through these neoadjuvant trials, what do we have? And what do we have? We have tumor in place that's been biopsied before, that's been treated, and then has been taken out. So we can see the treatment effect. And treatment effect help us figure out the most important part if we're gonna make this more of a personalized paradigm. You know, we are not all the same. I wear a extra large jacket and somebody else may wear a medium jacket. We may need different things. So predictive biomarkers are now coming by looking at the blood and the tissue of these patients being treated neoadjuvantly with different regimens. So we can figure out who does well and who will only need one drug, who needs two drugs, who can't even benefit, and move forward. So we look at while they're on therapy, what happens, and then after the surgery, what happens, and whether they have a response or not helps us to understand how to move forward. So a lot is being done here. And this stuff will help not only in the adjuvant or the neoadjuvant, we're hopeful it'll help us to be able to turn this stuff around rapidly to choose the best first-line therapy in the metastatic setting. And not just for skin melanoma, but also for mucosal melanomas and acromelanomas and ocular melanomas. And then behind those people in line are the other tumors waiting for us to navigate this and put down a roadmap on how this can help other tumors that require this type of therapies. All right, so a lot there. Well, what happens if you show up to my door and you've already had the surgery and you say, well, I heard all about this neoadjuvant stuff. I didn't get it. How can I benefit in that way? Well, that's where this idea of a neoantigen comes into place. Remember, I used it well the way back when I talked about that cartoon. So neoantigens are proteins that are expressed on the tumor that are novel, or neo, that's the neo part, novel proteins that are foreign to our immune system. Okay, well, how can I utilize that? Well, this is where the Moderna mRNA vaccine comes in. And yes, it's similar to the Moderna vaccines that you've been exposed to in the past. Vaccines work in the way that they stimulate your immune system to recognize a foreign part of an invader, similar to how bloodhounds sniff the shoe of an escaped convict. So these neoantigens, if you have some tissue, can be utilized to make a vaccine. And this is what this is. This is a neoantigen vaccine. It picks the 34 neoantigens that are responsible for that tumor. If you have tissue sitting somewhere on these protocols, which are not standard yet, but hopefully will be soon, these vaccines are made based on the way that these neoantigens are spliced and put forward onto your tumor, right? And so you get vaccinated, and that primes the immune system then to be boosted. And what are you vaccinated against? Those antigens that are specific for your tumors. So it is somewhere in between the top and the bottom, that you've had the surgery, but the tissue that's been taken out, the main immunogenic portion is introduced into your body along with your immunotherapy. And this is the trial that has been done and is ongoing. It was for high-risk melanomas in stage 3, and it did show what we wanted: relapse-free survival advantage. Again, a significant relapse-free survival advantage, and it continued as you look further and further. And I've shown you, as we updated it, it still stayed. Distant metastases-free survival benefits were there, and as I've shown you, step by step by step, we have built a paradigm of how to help patients before the surgery, after the surgery, stage 3 and stage 4, and stage 2. Hopefully, this in the future, you could take a very high-risk stage 2 and make a vaccine against it and move forward. But overall survival, encouraging. We still need to see more events. But guess what? A 1,200 patient randomized study has already been accrued, and we look forward to data coming from it in the next year or so. As I end, I'll bring forth a couple of other ideas. And that is, just like in the metastatic setting, we have seen response happen even after one dose of these drugs. So there are multiple trials looking to decrease the amount of time you're on adjuvant or neoadjuvant, whether it goes from what's standard now, 12 months of therapy, to 6 months of therapy. And Europeans are looking at a trial, Grand Slam, that is randomizing patients neoadjuvant or adjuvant to 6 months versus a full year. What about newer drugs? And this is Radaba Amaria from MD Anderson's trial. You don't need to know all the schmutz, but it used neoadjuvant relatlimab nivolumab, LAG-3 PD-1, and still showed high benefit rates. Who will do well with one or the other is still left to be teased out. How about how much surgery do you need? And the lovely and talented surgeons, the surgical oncologists, led by Dr. Mark Ferries, who will be speaking shortly, have proposed a plan to look to see if you really need to take out a lot of lymph nodes in the neoadjuvant setting, or if you have a major response, you just take out the affected nodes and monitor. That's coming up. What are we doing? We're showing the ability to affect long-term outcomes by standard regimens that are viable in the metastatic setting, move it to the adjuvant setting with high-risk stage 3 disease, move it to the stage 2 setting with high-risk disease, work to increase the responses, and then decrease the amount of therapy you need from a year to 6 months or less, identify who does well with what, and decrease the amount of surgery that you need. So I will just show this and say there are paradigms looking even to our patients with earlier and earlier stage 1 disease, and that's coming forward. What I like the most about this meeting is the ability to work, to talk, and collaborate with colleagues. This is the aforementioned Dr. Blanc, who brought us the Nadina trial. And with that, I will stop sharing, and thank you for listening, and allow us to now move into the next step. What's coming down the pike, Dr. Mami? What are the newer options?
Okay, so this is probably one of the most challenging presentation to prepare for because there is so much going on, which is not a bad thing overall, because it does lead to improvement of overall care for our patients, getting them newer options, less cytotoxic or toxic options, perhaps short treatments to improve their quality of life, letting them do the things they want to. But nonetheless, number of things that are going on. I'll try to summarize some of those. First of all, let's look at the Checkmate 067 slide that you've seen from Dr. Hamid at times and Dr. Moyers today. Look at, not all of the melanomas are responding, or at least cutaneous melanoma are responding to Opdivo and Yervoy or Ipi/Nivo. Some melanomas, their progression is early and the others later, and that key point is thought to be 6 months. But 2/3 of the patients actually tend not to respond. Only 1/3 have most durable response, and out of those 2/3, you'll see that some patients will their melanoma will fail much earlier. That's called the primary resistance, and that's number of reasons and listed there why these patients their melanoma doesn't respond to ipilimumab, nivolumab, and other fail at a later time, and that's called the secondary resistance. And again, there are a number of reasons for that. Dr. Katie Campbell, who's at UCLA, I think she's done with her PhD or close to it. She was looking at some of this translational data from SWOG S1616 trial that looked at patients whose melanoma didn't improve on one drug, either nivolumab or pembrolizumab, and then they were randomized to get either ipilimumab alone or combination. And we now know that the combination does a lot better than single agent ipilimumab. But what Dr. Campbell did was look at what are some of the markers in these melanomas that could tell us with some certainty that this patient's going to do better on this treatment, or if they've had resistant disease or not. And one of the key was having plasma cells or CD4 positive T regulatory cells in the tumor microenvironment that was essentially portending not very good prognosis, amongst other things. So the next question is, can we change this microenvironment through a number of different mechanisms? Can we use more drugs? Can we use different drugs? Can we use activated cells to overcome this resistance? So that's what I'm going to try to demonstrate here. So this is something that Dr. Moyers already brought to you: efficacy and safety of triplet nivolumab, relatlimab, ipilimumab in advanced melanoma that hadn't been treated before. This is the Relativity 048 study presented by Dr. Paulo Esierto last year at our American Society of Clinical Oncology meeting happening soon this year. And this showed that, the exploratory endpoint overall survival was very good in these limited number of patients that were treated. Based on this, Dr. Weber's brainchild here, clinical trial NYU S22-00325, which is looking at the combination of these three drugs and combining with interleukin-6 receptor blocking antibody, sirolimus. The intention is to reduce the toxicity of it and perhaps improve overall outcomes. And ongoing trial with some data being presented at ASCO this year, so stay tuned. Again, ongoing study now in a randomized fashion where a group of patients will be treated with the 3 drugs directed against melanoma, and the other group will be treated with 3 drugs against melanoma and sirolimus, and comparing their outcomes as far as the toxicity is concerned. The other option is, so that was, trying to use more drugs to kind of overcome that resistance. Can we capture those individuals whose melanoma may have not responded to 2 drugs? Can we give them 3 drugs? The other option is, we know that ipilimumab is very important in immune function against melanoma, and that's demonstrated when we looked at ipilimumab dose of 1 milligram per kilogram, 3 milligram per kilogram, and 10 milligram per kilogram. The toxicity goes up. And Dr. Moore has also shown you that when we see toxic events, that is in itself an indication of response. Does it mean more toxicity, more response? We don't know that yet, but still the data has shown that the higher dose of ipilimumab potentially leads to better outcomes against melanoma at risk of toxicity. So the next question is, can we improve this CTLA-4 blocking function? Can we design a drug that could potentially give us the higher dose, but not the toxicity for benefit? And that was the attempt by BioAtlas, conditionally active CTLA-4 antibody, which when moves into the tumor microenvironment, which is more acidic, it dissociated from a blocking counterpart and allows the CTLA-4 blocking mechanism to be active in tumor microenvironment alone and not away from it, thus reducing toxicity and improving benefit. And some of this data has been presented, and we've seen benefit in the first line setting and potential benefit in the second line setting, and ongoing study, and we'll see how it develops. So giving more than 2 drugs, perhaps a way to overcome resistance or prevent resistance, using a higher dose of ipilimumab to overcome resistance or prevent resistance. Again, the same slide showing, that population of plasma cells and CD4 positive T cell, these immune cells. Unfortunately, it's not able to be done in a usual pathology lab. These are specialty labs, and this data is still sort of in a research setting and not gone completely public yet. So, but still, this is something that's developing. And can we modify these? Reduce the number of these CD4 T regulatory cells to improve the immunotherapy that's already available to us. And that's the function of sort of the hope of this particular study by Georgia Immune using GIM531 small molecule inhibitor that inhibits an AKT3 enzyme important for T regulatory cell maintenance and activation. And by blocking that, you're reducing the function of CD4 T regulatory cells and not allowing those regulatory cells to impede function of the important lymphocytes in control of melanoma. Ongoing trial, open at multiple places along with Angela's clinic, and look forward to the benefit from or the data from this study. How about oncolytics? And some of this we've talked about in ocular melanoma with RP2, in cutaneous melanoma with RP1. These are the next generation oncolytic viruses, TVEC being the first generation. And the thought is that the composition of the RP family of modified HSV viruses is a lot different, and the GAL-V fusion protein allows additional function for immune stimulation, and that's why you're seeing these benefits not only in the injected but also in the non-injected lesions. Okay, this is the data that Dr. Moyers have talked about. RP1 initial Arcticus data showing benefit in a number of patients with RP1 approach. And actually, this is another important study that is complete, and we're waiting for the final results. A while back, when immune therapy combinations were still sort of in their early development, IDO inhibition was very important. We knew it was important, and initially it was attempted with the epcadostat in combination with pembrolizumab. Unfortunately, the late phase study didn't show the benefit, but that is making a comeback with IDO1 and PD-L1 sort of vaccine in combination with Pembro, and it's shown initial results been very good. And we're waiting on the phase 3 study results. As you can see, that this is in the first line setting, published in Nature Medicine, showing a lot of these waterfall plots with the bars pointing downwards rather than upwards, showing you improvement in melanoma metastases in combination with nivolumab. They showed 50% complete responses at a median follow-up of 45.3 months, 25.5 months in median progression-free survival, and median overall survival has not been reached yet. Only 17% of the patients has toxicity significant enough to discontinue therapy, which is again very good indicator. Overall response rate in first line setting at 80%, probably the best response rate that we've seen so far. Again, this is in a limited number of population of patients, and we're looking for the phase 3 data to show us more benefit. So this is trial design of the phase 3 study that's completed, and we're waiting for results. So one of the other ways that I talked about earlier was, targeting a particular antigen with perhaps activated T cells or TCRTs or T cell receptor targeting therapy. PRAME is an antigen that very strongly expressed in a number of different melanomas, cutaneous being one of them. And here the patients are getting actually sort of engineered PRAME targeting T cells. And these are the patients who've seen a number of different treatment options before. I'm sorry, the slide's a bit blurry here, but it shows that on the spider plot, a lot of those legs are below the line, the arbitrary line where you see the response, and showing ongoing response, improved progression-free survival, improved overall survival in these patients. Again, an option that is hopefully coming up very soon with late phase data as well. So another way to sort of bring those active T cells to control melanoma is trafficking those cells from periphery into the tumor using ImmTACs that we talked about in uveal melanoma talk. And this particular ImmTAC is targeting PRAME, also important in cutaneous melanoma, non-small cell lung cancer, squamous cell lung cancer, and others. Ovarian ongoing data. This is a trial that's actually in multiple different solid tumors that's ongoing, but focusing on brenetafusp or the PRAME targeting ImmTAC in melanoma, showing its benefit in PRAME positive with overall survival benefit. And that led to the PRISM-MEL 301 study, which is a first-line study in cutaneous melanoma, phase 3 study comparing nivolumab in combination with brenetafusp to nivolumab and relatlimab or nivolumab alone. 325 patients in each arm, large study that hopefully will give us another option to consider for our patients. So we've looked at combining multiple drugs, perhaps increasing dose of ipilimumab, using next generation immune stimulant viral products. Then we talked about using PRAME targets. And now what about the tumor microenvironment that hosts these active T cells, but for some reason aren't active enough to control melanoma? And that's already been introduced to you by Dr. Moyers with lifileucel from Iovance that's shown benefit in heavily pretreated melanoma patients with benefit that has gone on to get FDA approval in second-line setting. And Dr. Thomas from Orlando actually shown the first-line data showing, previously untreated patients with a very good benefit, with overall response rate of 65%, complete response of 30.4% in metastatic melanoma. And the confirmatory study is ongoing with comparing lifileucel with pembrolizumab to pembrolizumab alone, and we'll see its outcome in the future. How about using engineered TILs? I think Dr. Faris is going to go into much more detail about this, but Obsidian's product OBX-115 is an interleukin-2 sparing drug. We know that a lot of the toxicity for our patients for TILs come in from interleukin-2 administration as well, and older therapeutic options, very good options in the past nonetheless. And these are the patients they've seen a multiple number of therapies before, and shown its benefit. Ongoing study for both non-small cell lung cancer and metastatic melanoma of cutaneous origin. Again, the early phase data, or a small subset of data, was presented at ASCO a year ago, and again, the basis of this ongoing study. Other ways to sort of improve the tumor infiltrating lymphocytes is PD-1 knockout, and that's the Iovance's attempt at improving their TIL lifileucel to the sort of maybe TIL 2.0, and we'll see what that data shows. It's an ongoing study available at multiple different sites. Again, T-cell receptor-based therapy is very interesting because it recognizes greater number of intracellular tumor-specific or associated antigen or neo-adjuvant that cannot be targeted with either immunoglobulins, for example, your run-of-the-mill immunotherapies, or CARs, and NK cells that do not express TCR, so there's no risk of mispairing or risk of off-target toxicity. Again, number of different trials that are looking at CAR-19, IL-15, NK cell therapies in lymphoid or heme malignancies with established benefit in small number of patients. Durability of response, overall survival in single-arm studies been established. Number of different options that are in development that Dr. Faris will talk to you about in a few minutes. Last slide here is, how about activating the NK cell population within the tumor microenvironment? This is an ongoing study, GV20, that data has been presented at a number of different conferences. I think there is an abstract at ASCO this year that's updating all of these patients' data and showing us responses in refractory melanoma patients.
Okay. So you can tell that Dr. Memi has been here for 5 years, as he's picked up the traditional Hamid approach, too many slides for the amount of time. But it's just to prove that there's a lot of work ongoing here for our program, for our patients to move things forward. The push for patients at any stage, at any time, to ask questions like you're doing here and to be evaluated for other therapies. We've saved the best for last, is what we say when we make one of our colleagues wait till the end to speak, but this is true today. One of the greatest pleasures of my career is to be working side by side and to host this meeting and to run the cutaneous program here at Angela's Clinic, Cedars-Sinai, with Dr. Mark Faris. And I won't say more because he'll show it to you. He's an amazing physician, surgeon, and speaker.
All right, thanks so much. I've enjoyed the sessions, and I'll give the audience a sense of relief that I'll try not to include too much more data here. You may be data out at the moment. Lots of information, lots of good information. But I'll try and go back to the beginning in some ways and then bring you up to speed a little bit terms of where we stand with cellular therapies, T-cell therapies. And so in terms of what I'll cover, what is a T-cell? What are we even talking about? What does it do? How does it work? And why are we interested in it? How do we come to use T-cells as a treatment, and why did it take so long to get here? And then how are we improving this therapy as we move into the future? So, basically we know and have known for a long time that the immune system has the ability to detect cancer, to recognize it as abnormal and even attack it. So this is just a slide of a biopsy under the microscope of a melanoma, just a melanoma in the skin. And the melanoma cells are the big cells at the top. And all of those little dark blue cells at the bottom are lymphocytes, many of which are T cells. And you can see a few of them are making their way up into the tumor. And they're not there by accident. And we actually didn't do anything to make them go there. They just went there on their own. They were able to recognize that there was something wrong with these melanoma cells, and they are trying to deal with them. And so this has been known for a long time that this happens. And these immunotherapies that you're hearing about are ways in which this ability has been taken advantage of as a form of treatment. And so this goes way back. So this William Bradford Coley, he was a surgeon in New York at the end of the 19th century. And he noted that occasionally a tumor might get infected as a result of growing too much, and then would spontaneously regress, go away. And so he literally cooked up mixtures of bacterial toxins from various cultures and injected those into tumors. He knew that he had gotten the right dose when the patient developed a fever to 102 or 103, and actually saw quite a number of regressions of tumors that he injected. But it wasn't very reproducible. And at the time, it was a one-shop sort of operation, and wasn't really able to spread out to other locations in a meaningful way. And when other cancer therapies came along, it sort of fell by the wayside. But it has been maintained, this sort of idea has been maintained specifically in melanoma over the years, really since the 70s and 80s. And my mentor, Don Morton, developed the concept of injecting something called BCG into melanomas. And we still occasionally do this, but this is similar to the TVEC that you've heard about, the RP1 that you've heard about, where we inject something into the tumor to cause something to happen there with the hopes of making other tumors go away with that injection. So this is just a case of a woman that we treated years ago who had what are called in-transit metastases. These are metastases of melanoma in the skin, and you can see she has hundreds of them on her leg and backside there, and so no way to operate on this, no way to do regional chemotherapy for it. This was before the days of Yervoy and Keytruda and such, and so we injected a proportion of these tumors with BCG. And you can see there was inflammation that developed at the sites of the tumors that we injected. And those tumors that we injected went away, but the rest of the tumors went away too. And so these spots that you see that are left there now are just pigment tattoos, basically, and all the melanoma was gone. So this really, even before we knew that much about the immune system, proved the concept that we could harness the immune system to kill tumors. And so what's happened is there's been an explosion of effective therapies in melanoma. You can see through the 70s and 80s and into the 2000s, we had almost nothing to offer, very, very little to offer. And then there have been this raft of treatments that have come along. All the ones that are in the blue boxes are immune therapies, and they are all dependent on T cells to work. So how does all this operate? So if you take a cell, any cell, and look at how it works, how it functions, there's DNA in the nucleus, and that then produces mRNA, same things that are made into these vaccines, but the body does it on its own. The mRNAs then pass through a ribosome and are converted into proteins. And one of the ways that the body works to sort of maintain itself, these proteins are broken down in something called a proteasome, the peptides, and those peptide fragments are then loaded into something called MHC or HLA. And so when you have this tissue typing done, when you look to see if you're eligible for some of these bispecific antibodies, those sorts of things, this is the specificity that's being looked at, these immune cells. And these are really the context in which these peptides are presented. This is a way for the cell to say what's going on inside the cell. And the importance of all of this is that is how T cells determine whether a cell is a good cell or a bad cell. So the T cells then come into play. They come in and interact here and take a look at what peptides are being presented. So if there are mutations in the proteins, mutations in the DNA that lead to abnormal proteins, these neo-antigens, those get loaded in here. The T cells can recognize it as not a normal cell and know to kill it. And the T cell's job is to kill those cells. And so the way a lot of these therapies work is we manipulate this interaction in a way that enhances the ability of those T cells to kill the melanoma cells. And there are those T cells again that you saw from before. So in terms of immunotherapy, you have melanoma cells, the T cells go and find them and hopefully kill them. That the dying cells potentially then release antigens that can be picked up by antigen presenting cells, another type of immune cell. They can then mature into these dendritic cells that are very effective at stimulating and multiplying that immune response. And we can impact that. That can be impacted by helper cells, it can be blunted by regulatory cells. We now have these drugs that we can use that work through this system. So one of the drugs that you're familiar with is Yervoy or ipilimumab. And that probably works at this interaction between the antigen presenting cell, the cell that's supposed to stimulate the T cell to go off and do what it's supposed to do, educated basically. And there's an interaction between the antigen presenting cell and the T cell with something called CD28. That activates that T cell, it then goes off to find the melanoma cells and kill them. And then eventually it circulates back around and may interact again with an antigen presenting cell. But now it has something called CTLA4 on its surface instead. And that interaction actually shuts that T cell off. It's a way the immune system normally turns itself off when an infection is cleared, that sort of thing. But this can be used in the setting of tumors for the tumors to escape. And so Yervoy is something that blocks that CTLA4, keeps that from happening, keeps those T cells turned on. That's sort of like a handbrake in a car. The other kind of brake in this system happens actually directly between the T cell and the melanoma cell. So more like the foot pedal brake. And here those cells come into contact with this interaction. The T cell potentially could kill that tumor cell, recognizing it as normal, but it may have this PD-1 on its surface that can interact potentially with PD-L1 on the surface of the tumor cell. And that interaction shuts that T cell off as well. And so the Keytrudas, the Opdivos, they keep that from happening and allow those cells to continue on to kill those melanoma cells. And so we have learned in this cycle of the tumor cells, the immune system, how to manipulate the interactions. And so we can interact at the CTLA4, at the PD-1, you've heard about LAG3, but it's not that simple even. There are ways of killing tumor cells to release more antigen or produce more immune response. You can increase the maturation of these dendritic cells with various things and presentation of antigens. You can affect the other regulators of the immune system. You can apply various cytokines and binding proteins. And anyway, it gets a little complicated. For the simple-minded surgeon, it may be, above my level. So we think about just using T cells, a fairly simple concept, just sending them in, sort of like a cruise missile, fully packaged melanoma killing machines. And how can we do that? And that's this adoptive immunotherapy or T cell based immunotherapy. And so this is a therapy that has been was pioneered by a guy named Steve Rosenberg, who's led the surgery branch at the NCI for many years, and just sort of emphasizing the incredible contributions that the NCI and the National Institutes of Health have made to cancer research over the years. And so the idea that Dr. Rosenberg had was that we know that these lymphocytes can infiltrate tumors in the body. We can surgically take those tumors out And if you look at the tumors outside of the body, you can find those T cells that are in there again. But you can take some of that tumor tissue and actually put it into culture in the lab in conditions that favor the growth of the immune cells. And those immune cells will grow up in those culture wells and kill the tumor that's in there. And then you can take those T cells actually and test them outside of the body and see if they kill melanoma cells outside of the body. And you can also expand them through a culture conditions called rapid expansion protocol to increase the numbers into many billions of cells. And those cells then can be given back through an IV into patients with melanoma with the hopes that those T cells will be strengthened in numbers and in ability so that they can then kill the tumor cells that are in the patient. And it clearly works. We've known it has worked for some time. These are just case examples that came from the NCI of tumors that shrink and go away, often in a rapid fashion after infusion of these cells. But this is a fairly complicated treatment, as you can imagine. And for many years, it was only done at places like the National Cancer Institute or MD Anderson, places you need a Google Earth to be able to actually see the whole place. And so it wasn't felt that it was going to be practical to be used outside of those sorts of places. Dr. Hamid and I were crazy enough to start our own TIL protocol years ago and had a cellular growth lab. And there's a cellular product that we made that we gave to a patient. But it was a pretty heavy lift and wasn't going to be something that would become mainstream. But now it is mainstream. And that is due to collaboration with commercial partners that have enabled the production of these cells in a practical way. So the first cells to the finish line for this were CAR T cells used in lymphomas, leukemias. And there are many companies that were involved in developing those CAR T cells, CAR NK cells, and then TIL, the main focus here, these tumor infiltrating lymphocytes that are grown, and a bunch of companies that are working on that. The ones that were first to the finish line in terms of approval of FDA approval for a product were Iovance and Adaptimmune, who both have FDA approvals now for their products, and then they're available now outside of a clinical trial. The trial that led to the approval of that TIL treatment from Iovance was this one. You see Dr. Hamid's name there as second in the list. And the way the process works from the patient's perspective, there's a tumor that's taken out. It is cultured through this multi-step process in the lab. The culture process itself takes about 3 weeks, a little over 3 weeks. From the patient's perspective, they have the tumor removed, surgically removed. And then there's a period where they're waiting and that process goes on. It's actually probably more like 5 or 6 weeks. Typically it takes between the time when the tumor is taken out and the cells are given back because there are quality control things that need to happen and other things that delay the treatment itself. When the patients get the cells, they have been recently then treated with what's called lymphodepletion. It's chemotherapy that's designed to get rid of the lymphocytes that they have in circulation already and essentially create space for the lymphocytes that are about to be infused. And then they get this interleukin-2, that cytokine that you heard about, that's a lymphocyte growth factor that supports those cells after they've been infused. And this is that waterfall plot, and this is maybe the only sort of plot that I have for you guys that shows these downward bars, and that represents shrinkage of the tumor. And you can see that happen in the vast majority of the patients. There was some shrinkage of their tumor. The patients that experienced responses, those responses most of the time were durable. So lasted for over 2 years in this level of the follow-up. So it seemed like this one-time, once and done sort of treatment did have a lasting benefit for the patients that responded well. And so it had approval last year. There are a lot of challenges with this therapy, though. It is not for everyone. There is the delay in terms of timing between when the tumor is harvested and when the patients actually get the treatment. We need to have surgery to get the tumor out, and we need to balance the risk of a procedure for removing the tumor with being able to get a sufficient sample to be able to create the therapy. There's toxicity associated with the chemotherapy they get in preparation, and there's toxicity that's associated with that IL-2 they get to support those cells afterward. And then it doesn't work for everyone. Even when we can get cells for people, it doesn't cause the tumors to go away for all those patients for a variety of reasons. And so those are the areas, all of these areas are areas that there's work being done to try to improve the therapy to make it available and effective for more people. Just an example of a patient that we treated in terms of the surgical planning for this and selecting the appropriate tumor. The patient had had a lot of different previous therapies and was now going to get TIL, and had a tumor, a very small tumor here in the liver, a very big tumor in the right adrenal gland, and then another small tumor just in the soft tissue. So for this setting, the small soft tissue lesion was clearly the right one to get to without causing a lot of toxicity from the surgery itself, but providing a sufficient sample to make TIL out of. So how are we altering these regimens to try to improve the therapy? You can step up the timing, moving it earlier so the patients have more time to get there, potentially reduce the intensity of some of these conditioning regimens, selecting better lymphocytes from the tumor to potentially use, combining these therapies with the other effective interventions that we have, PD-1 blockade, other novel interventions, and then delivering the tumors, the cells in different ways, and then modifying the TIL themselves to try to make them more effective, and show you some examples of how that may work. One is with altering the T cell receptor, or the thing that makes the T cell able to identify a very, very specific target. And that's that T cell receptor. And so there are a couple of ways of doing that. One is by taking out peripheral blood lymphocytes, and those lymphocytes then can be altered. You can introduce genes into those cells that change from one T cell receptor to another one that we know is very specific for a melanoma target. So these are transgenic T cell receptors. The other way is with these CAR T cells, chimeric antigen receptor T cells, where a gene is introduced into these cells. It makes them put on their surface what is essentially like an antibody, but it is linked to the same T cell signaling that would be in a normal T cell receptor. And so then these modified things can come up against either the peptide in this MHC, just like the normal T cell kind of interaction, or by recognizing a cell surface protein through this antibody type molecule. And these different approaches have pros and cons to them about what the targets can be, those sorts of things. And so both approaches may have value. The other thing that can be done is altering the function of these T cells. So this is just the standard TIL, that is the TIL that have been selected because we already know they make their way into tumors. They have the right T cell receptors to do that already. But instead of relying on exogenous interleukin-2, that cytokine that has all the toxicity to bind to IL-2 receptors, these cells, these are the OBX115 cells that Dr. Memi mentioned, have a gene introduced so that they have a membrane-bound IL-15, another T cell stimulating cytokine on their surface. And then they can be given this small molecule drug that activates that. It's essentially an on switch for that. And the cells stimulate themselves. You don't have to give the IL-2. So this may be a way of avoiding that toxicity. There are lots of potential immunologic hurdles to get over with immunosuppressive environments and antigen escape and those sorts of things. And there are ways of modifying these T cell receptors, either chimeric antigen receptors or T cell receptors, to try and overcome those difficulties. And then a separate type of cell that can be used as a cellular therapy are NK cells. These are natural killer cells that may have an inherent ability to recognize and kill cancer cells. So overall, it's clear now to us that T cells are critical components of immunotherapies, these adoptive immunotherapies, but also the checkpoint immunotherapies you've heard about. You need T cells to be working for any of those to work. There are still challenges in applying TIL therapy to patients more broadly that we are working with ongoing research to try to overcome. try and make these cell therapies available to as many patients as possible. And this, as you can imagine, is an enormous team effort. So the TIL therapy is very complicated and requires a bunch of people with a bunch of different types of expertise. This is the Angeles Clinic group with nurses and medical assistants and pharmacists and many, many others who make all this come together to work. So I appreciate the opportunity to participate in the symposium again. Thanks.
All right, so you can see why we kept Dr. Ferries for last. That was wonderful. And so as we come to the conclusion here, we have Ann Taylor on to remind me that we have lots of questions and answers to go through. So we'll go through them and I'll throw them around. So we'll go for Dr. Memi. At what stage of melanoma are you eligible to receive oncolytic viruses?
So the simplest answer is probably, advanced stage, either, stage 3, that's advanced, or stage 4 disease. But working with Dr. Ferries, a lot of the times we do look at some of these patients who have disease limited to small space, either scalp or legs or any other part of the body where there's just too much disease there, nodules around the primary tumor, and we use it in that particular situation as well. But the therapies that we've talked about, RP1, RP2, they're essentially looking at more advanced melanomas.
Okay, good. This one would be for Dr. Moyers. I'm gonna decrease Eric's question down. So, hey, what is your frequency of surveillance and how do you surveil your patients in the adjuvant setting and in the metastatic setting?
Yeah, so I think the easy one is the metastatic setting. So if anybody has active tumors, I think most people will do about every 3 months or so. And then once they get into a remission, then that's kind of where the questions, kind of go. I think people will look from between 3 months to every 12 months. Kind of depends on the tempo of disease. Sometimes you'll augment that with adding in like ctDNA testing. That's one strategy some people use. But the real answer is we don't have a randomized trial to answer this, and it's kind of something that you have to figure out with your doctor. In the adjuvant setting, after a curative surgery and immunotherapy, there's some guidelines, but I think often people will do every 3 months for the first 2 years with imaging, and then it can lengthen out after that to maybe every 6 months for the next year or two, and then yearly, up to year 5 sometimes, depending on people's discussion with their oncologist, can go longer and can be more frequent depending on if they're having their prior tempo disease. And then we always tell our patients, if you have any new changes or new side effects, talk to us because maybe we'll do a scan early.
Okay, good. Let's go to one that I'll answer. I think it'll cover 2 of the questions. So what happens if you are receiving immunotherapy and you get a toxicity and you're having a response or not a response? How do things go from there? I will say that as we presented and I have seen, you may have a great response even after a couple of doses of therapy. In the initial trials for patients who were on immune checkpoint inhibitors and got toxicities, we have seen that up to 2/3 of them, if they're having a response, if you stop therapy, will continue to have that response. So the durability then pushes itself out now. if you have a toxicity that's not getting better, there are clinical trials for that. Specifically, there's one ongoing comparing initial steroids versus steroids plus an antibody therapy for myocarditis. But it is important, if you're having a toxicity that you're not getting over, to seek some consultation from people who have expertise. And that's part of, you will all agree, part of our clinical picture now for our referrals. And I will say that none of this excludes a person who needs a next line of therapy, who's had a significant side effect from standard therapies. And there were trials that were presented here, discussions about TIL therapy, and that's been given to people who've had checkpoint inhibitor toxicities. Some of the newer antibodies that were presented here can be given in that setting. Oncolytics have been given in that setting. And then, of course, one thing that we haven't said, targeted agents, that's why everybody gets genomic sequencing, do not have the same toxicity profile. So with that, there's a lot to do. And it's not just coming to a site of excellence for treatment. It is because these therapies have become so complex and intricate, the utilization of a melanoma opinion leader or expert to guide and help make decisions along with your local oncologist as a team. You know, no athlete succeeds alone. They have trainers, they have a nutritionist, they have X, Y, and Z. And the same for any patient who has a difficult to treat diagnosis. You need your local oncologist, you need an expert to help you, you need a trialist for places where you get this stuck, you need supportive surgical oncology to ensure that we get you to the TIL, that we get rid of areas that are of concern and can cause morbidity, allow you to get future therapies. We don't bring on a radiation oncologist because they're pretty much out of the office by 3:30, but we utilize radiation oncologists a lot for collaboration. So lengthy answer to a couple of questions, and as we move forward. So the next one is for Dr. Ferries. This hepatic perfusion for ocular melanoma, can you expand on that? The data, how it's done, and what we're seeing?
Yeah, so the regional perfusion is something that goes way back in melanoma as well. And you saw those pictures of the woman's leg with all the intransit metastases in it. And we'll sometimes see patients with the cutaneous melanoma that's isolated to an arm or a specific limb. And for many years, the regional perfusions were done to treat melanomas of the arms and legs by isolating the blood flow in and out of the limb and giving high doses of chemotherapy, high enough doses that you could get melanoma, which usually doesn't respond very well to chemotherapy. You can get it to respond. So the same thing happens for uveal melanoma patients, where their melanoma will spread, but spread only to the liver. And so originally there was a surgical technique where the liver was isolated, all the blood vessels in and out of the liver were surgically isolated, so that the same thing could be done. The chemotherapy could be given to the liver, but just the liver, so you get much higher doses. But you can imagine that as a very invasive operation to do that. Can only be done once, can only be done in very healthy people. And so what this current hepatic perfusion technique is actually a percutaneous way of doing that. So just as now things like aortic aneurysms and aortic valve problems are fixed just with catheters, minimally invasively, that's what this does. And it's a way of inserting catheters that isolate the blood flow that comes out of the liver, so that when the chemotherapy is given, all of that chemotherapy-laden blood can be drained outside of the body. It passes through these activated carbon filters that remove the chemotherapy from the blood, and then that cleansed blood is given back to the patient into the circulation. And so that enables us to give very high doses of chemotherapy that can get responses. And now 2 randomized phase 3 trials that have been done that were successful, showing benefits of doing this for these uveal melanoma patients. Now the treatment is approved in the US, FDA approved, and is available at centers that are authorized to give it, and we are one of those centers.
Thank you. I'm going to take a little bit of a break to do something that we wanted to, and that's to give Ann Taylor a little bit of a soapbox to discuss why we desperately needed AIM and what AIM does, how to get involved.
Thank you. Thank you so much. I appreciate that opportunity. Let me share. I have a short PowerPoint that I would like to share. Let's see. I don't see. There it is. Okay. Oh, there it is.
Oh,
Okay. I hope everyone can see that. See my PowerPoint. I need to hang on just a second. I need to start my slideshow from the beginning. For those that aren't familiar, who have joined us this evening and are not familiar with AIM at Melanoma, it was founded 20 years ago by Valerie Guild after her daughter, Charlie, passed away. She was diagnosed with melanoma and unfortunately did not respond to what at the time was the only FDA-approved treatment. And so she founded AIM at Melanoma with three purposes. The first was to try to find a cure for melanoma and to work alongside of the researchers across the world to see what research would have the most positive impact so that we could find a cure for melanoma in our lifetime. Also, there's a lot of legislation and advocacy that we have done to try to support education in the community for sun safety and skin cancer prevention. And finally, we built a website that supports the community as they work through their melanoma treatment. And it's that website that I'd like to take just a few minutes as a patient advocate. I'd like so much to make sure that the community is aware that these resources are available to them, education and resources at no cost. The first and by far the most frequently visited web pages are those on stage and related treatment information, but also we have side effect management guides. We've been talking about the toxicity related to immunotherapy this evening, and we have side effect management guides that people find very, very helpful. In addition, we have a section of our website we recently updated on melanoma clinical trials, and we have a melanoma matching service that you can take advantage of. One of the services that's most popular by far is our Ask a Medical Expert. We have a colleague, Melissa Wilson, a PA who works at UPMC Hillman Cancer Center, and we have a form that you can fill out. She is not, her role is not to change your plan of care, but rather to make sure that patients understand the plan of care that's being put before them, the options that are being put before them, answer questions about what does it mean to be BRAF positive, or, what do some test results, mean for them, those kinds of questions that perhaps they didn't understand thoroughly. As a result of this particular service, she decided to do a webinar series called From the Clinic to the Living Room. So what she has put together about 18 wonderful webinars that explain some of these topics that are most often sent to her. And by far the most frequently watched webinar answers the question, I've been diagnosed with melanoma, now what? I want to talk about our symposiums for just a minute, but I want to skip next to our podcast. We have a podcast called Beyond the Clinic, Living Well with Melanoma. And what we do in these 30-minute sessions is we have a discussion about the emotional impact of being diagnosed with melanoma. How do you build a supportive circle? How do you manage the anxiety? Those kinds of topics. And Dr. Samantha Siegel, who is the director of the Cancer Survivorship Program at Kaiser Permanente, is both our host and also a cancer survivor. We have a large section offering information about support for caregivers, both information that helps them to offer care and support for those that they love, but also how to take care of themselves during the period of time when someone they love is being treated with melanoma. And lastly, I want to make sure that you're aware that we have a program called Peer Connect, which is a one-on-one survivor matching program. We have 50 volunteers across the country who have completed their melanoma journey, and now they want to act as a source of inspiration and encouragement to individuals who are still going through their treatment. And so if anyone is interested in learning more about that program, you need only reach out to AIM at Melanoma, and we will make that connection for you. And so lastly, I want to talk about these symposiums. We host 10 a year with cancer centers across the country. And we want to note the importance of the 15th year that AIM at Melanoma has been working alongside of the Angeles Clinic and co-hosting a symposium. Sam Guild is our president, and unfortunately, she had a conflict this evening and could not come. She has attended every other symposium that our two organizations have co-hosted together. And so she sends her apologies for not being able to come. But more importantly, she sent a message for Dr. Piro, Dr. Hamid, and the rest of the Angeles Clinic team that I want to read to you now. Sam says that she's been reflecting back over 15 years of co-hosting symposiums with Angeles Clinic, and she vividly recalls how some of those first symposiums were very hard. They were hard in the sense that many of the people that she met from previous symposiums were no longer with us when she would return the following year. Finally, though, over time, we thankfully turned the corner due to newly approved therapies and researchers' better understanding of how to treat patients. So AIM is delighted to continue to co-host this annual symposium with Angeles Clinic, where we get to share with all of you how these advances are improving the overall survival of patients and improving their quality of life. And we certainly look forward to another 15 years of working with the Angeles team, the Angeles Clinic team, in support of the melanoma community. So with that, I'll just say that I'll stop sharing, and I will say that if I can help anybody find things on our website, help you navigate the website, if I can connect you to a mentor, if there's anything that we can do to support you, please feel free to contact me, and I will put my email address, my contact information into the chat. And the very last thing is that I will be writing everyone at the conclusion of tonight's symposium. The most frequently asked question is, how can I see this symposium again? We know that you will want to. This symposium is being recorded. It will be available within 5 or 10 minutes in its entirety on our AIM at Melanoma YouTube platform. So you can go there. And then in addition to that, in about 2 weeks, we will have taken all of these presentations, divided them by topic, and then we will put them back onto the same registration where you registered to attend this evening. And then you would be able to share those and watch the individual presentations that are of the most interest to you. And so with that, Dr. Hamid, I will pass it back to you for our final questions. Thank you.
Thank you so much. And I will also state that once they chop those up, we will, before next year's symposium, take a look at the most visited one. That person will get to go first next year. All right, 2 small things here as we wrap up. And I want to just recognize that the idea for these symposiums was due to a discussion between Jeff Weber and myself and an introduction to Val Guild, where in Las Vegas, not at the craps table, but at a melanoma meeting, Val Guild and I on the back of a napkin scribbled out how this was to go. And it's just great to see it become an international phenomenon. We have lost Val to cancer, and we have lost Jeff to cancer. So the main fight here is not just for melanoma patients, it's for every patient. We'll end with 2 great questions. One for Dr. Ferries. This comes from Eric. Great question. He wins the award. Okay, I had a stage 1B melanoma off the top of my head, and it recurred many years later in a neck lymph node. Is that a situation where before surgery, I should be talking to someone about neo-adjuvant therapy?
So yeah, so anytime we have someone who presents with lymph node metastases that we can detect from the outside based on physical exam or scans, we now know pretty firmly that it's better to give them their first doses of immunotherapy before that tumor is taken out. And as you saw, there are lymphocytes in those tumors that are potentially effective. And if we take them out and put them in a jar, then they can't help us anymore. But if we give the immunotherapy and get them back on their feet before the surgery, that's definitely beneficial. That specific situation, even though there's been a decent amount of time in between when the original spot on the scalp was and when the nodes came back, that's a favorable thing. The longer it takes for that to happen, but still that's a pretty high risk situation, and you want to take advantage of every opportunity that you have. So the neo-adjuvant approach would be good for that.
That is great. So the last question is actually a great way to wrap up this meeting, because it is a question about what trials are available, how do we find them, how do you decide to refer, or how do you decide between trials? And the first step is picking up the phone and starting to create that team around the patient. Aim at Melanoma for education and support, a surgical oncologist to get to know the patient even before any surgery is needed, to help guide at every time point. An expert like Doctors Memi and Moyers, who've been here in the phase 1 and the drug development in melanoma. And of course, come back again to any one of these symposiums and you'll get the answers. With that, I want to thank everyone. I want to appreciate the people who are calling in from California, but also there's some crazy people on the East Coast who are joining us. And thank you so much. Bye-bye.